Hello everyone, welcome to Rehabilitation Sciences Group channel. Today, the second session today is on advanced management of adhesive capsulitis, and we have with us Dr. Varun Kalia. He'll be taking on that. Dr. Sagun, you can start the session now.
A very good evening, Dr. Varun.
Yeah, good evening, sir.
I think we are discussing a shoulder because we have seen a lot of times that problems in the shoulder are very common in our society, and we get a lot of patients on shoulder, and especially stiff shoulder. And a lot of times a diagnosis of adhesive capsulitis is made, but the treatment across clinics and across therapists is very different. And most of the times the treatment is so lengthy. I think after today's lecture, we'll have a lot more to think about on this important condition. To discuss about this, we have with us Dr. Varun Kalia, who is the HOD and Assistant Professor at the Department of Physiotherapy of the Saint Soldier College in Jalandhar, Punjab. He is also the Director of Keshav Kalia Physio World at Jalandhar City, Punjab. We welcome you, sir, and we will have a very interesting session with you today, sir.
Yeah, thank you, sir. Thanks a lot. As you said, I am Dr. Varun Kalia. Today, I will talk about the advanced management of adhesive capsulitis. First of all, I would like to thank Dr. Harpreet sir, Dr. Shagun Agarwal sir, and Dr. Dharam P. Pandey sir for giving me this best opportunity to interact with so many physios and clinicians and students. I'm very thankful to you, sir. So first one is the adhesive capsulitis. Adhesive capsulitis is having so many different names, but we know just one or two names about the adhesive capsulitis. But if we will see behind the centuries from 1850s, its name is continuously changing till now. Now we know this adhesive capsulitis, but in 1850s, it's known as 50s shoulder. And after that, it's continuously changing its names like obliterative bursitis, Duplass syndrome, frozen shoulder, stiff shoulder syndrome, pericapsulitis, periarthritis of shoulder, scapulohumeral periarthritis, and adherent subacromial bursitis. So all these names are of adhesive capsulitis. So what is adhesive capsulitis? It's a common musculoskeletal, painful and restrictive condition of unknown etiology. That means it's a very much common in today's scenario, but it's that much difficult to treat with the help of physiotherapy. And as you already said, it takes so much time to treat or to recover. So what is the incidence? If we will see the incidence, women are most affected with the adhesive capsulitis than the men. And if we will see the non-diabetic population, then 2 to 5% population is affected. But if we will see the diabetic population, then the 20% more population is affected with the adhesive capsulitis. So what is the pathology behind it? From the past decades, we are thinking that inflammation and fibrosis of joint capsule and coracohumeral ligament is the main culprit behind the adhesive capsulitis pathology. But in 2007, Hand GC et al. Said that its pathology still remain unclear. And in 2010, Page P et al. Said that adhesive capsulitis restriction is not just because of capsular and ligamentous tightness, but also facial restriction, muscular tightness, and trigger points are also responsible for it. So this is the new concept behind the pathology of the adhesive capsulitis. What is the clinical presentation? Here we have main three stages. First one is the acute freezing or painful stage. This stage lasts from 2 to 9 months, and here the gradual onset of shoulder pain at rest is present, and pain at night is also present with the sleep interruption. In stage 2, adhesive stage, or we can also say it's a stiffening stage, and at this stage pain starts to subside and progressive loss of glenohumeral motion in capsular pattern starts. Here, what is the capsular pattern for the shoulder joint? External rotation, then abduction, and then internal rotation. So, shoulder starts restriction in this capsular pattern. Pain is apparent only at extremes of movement. That means at the end range of movements, patients start feeling pain, extreme pain. This stage may occur at around 4 months but lasts till about 12 months. So it's a very long stage. And the third one, that is the last stage, is the resolution or thawing stage. In this stage, spontaneous progressive improvement of functional range of motion takes place. And this stage also lasts from 5 to 24 months, and it's a very much lengthy stage. So here we have main two symptoms. First one is the pain, second one is the joint stiffness. And we have to achieve our target. And what will be our target? Our target will be the complete shoulder range of motion without pain. And to achieve this target, we have different management or different treatment options. Like first one is the non-invasive techniques. We can divide non-invasive techniques into two categories. First one for pain relief and second one to increase range of motion. In pain relief, we all know for pain relief, we have electrotherapy management including low-level laser therapy, interferential current, therapeutic ultrasound, TENS, shortwave diathermy, and along with kinesio taping also. And to increase range of motions, we have Maitland mobilization, Mulligan mobilization, Spencer technique, stretching exercises, joint active systems, extracorporeal shockwave therapy, his device, and muscle energy technique. All these approaches are coming under physiotherapy uh, approaches or treatment. So we will discuss all these approaches one by one. But except the non-invasive techniques, we have minimally invasive techniques like corticosteroid injections, suprascapular nerve blocks, manipulation under anesthesia, capsular distension injections, and dry needling. First four techniques are not coming under the physiotherapy management. These techniques are coming under the surgeon's approach. So we will not discuss these four techniques. We will discuss only dry needling. And the last one, that is the completely invasive approach that includes arthroscopic or open surgical release. It's also coming under surgeon's approach. So we will not discuss this thing here. So first one, that is the electrotherapy. Here we will just discuss or we will tell some evidence-based management. Most of the authors or physicians or clinicians using this approach. First one is the laser therapy. Laser, what is the laser? Light amplification by stimulated emission of radiation. So we can use either 3A class or 3B class for the treatment of adhesive capsulitis. And we can use wavelength in between the 600 to 1000 nanometer, and power we can use 1 to 100 milliwatt, or mode we can use either continuous mode or pulse mode according to the condition of the patient. Next one is the IFT, that is the interferential therapy, and here we can use constant or sweep amplitude. If we will use constant amplitude, then our frequency will be the 110 hertz. And if we will go for the sweep amplitude, then our frequency will be the 80 to 110 hertz. And we can use the intensity at the tolerance level of the patient. Next is the therapeutic ultrasound. Here we can use either 1 or 3 megahertz. Then we can use the wavelength. If we will use the 1 megahertz, then wavelength would be the 1.5 mm, and if we will use 3 megahertz, then wavelength would be the 0.5 mm. And here we can use either continuous or pulse mode according to the patient condition. Next is the TENS. TENS is the transcutaneous electrical nerve stimulation, and here we can use pulse duration 0.2 millisecond, frequency 100 hertz, or treatment time will be the 20 minutes. Next is the shortwave diathermy. Frequency we can use 27.12 megahertz, or intensity according to the subjective feeling of comfortable warmth. We can increase the intensity. Next is the kinesio taping. So what is kinesio taping? The kinesio taping method is a definitive rehabilitative taping technique that is designed to facilitate the body's natural healing process while providing support and stability to muscles and joints without restricting the body's range of motion. Here we are not restricting the range of motion, we are just providing the support to the muscles and joint or supporting structures. So pain will be reduced. Here we can use different types of kinesio taping or different methods of kinesio taping, but one common method most of the physiotherapists are using, and I will discuss that method. In this method, the patient will be in sitting position with the shoulder in neutral position, and therapist palpate completely or effectively before applying kinesio taping. And after that, we will apply 3 pieces of kinesio taping. First piece we will touch the base and in between the center. Like this, you can see here. After tearing, we will start adhering the kinesio taping. We will start from the base of the kinesio taping. We will start just below the deltoid tuberosity, and then we have 2 strips for the anterior and posterior fibers of the deltoid. When we have to apply for the posterior fiber of the deltoid, then at that time patient have to move the shoulder in flexion range, so that the posterior fibers of the deltoid must be in stretch position. And when we have to apply for the anterior fiber, at that time shoulder is in extension position, so that anterior fibers in stretch position. And after that, patient have to maintain the shoulder in neutral position, and we will fix the ends of the kinesio tape. In the second piece of kinesio tape, we will again tear it from the base. Like this, you can see. Then we will start adhering the kinesio tape from the upper fibers of the trapezius, and then lower end of the tape we will adhere at the middle fibers of the deltoid by maintaining shoulder in 90 degree of abduction and medial rotation. Like this, you can see here. Like this. Next, the third piece of kinesio tape we will take, and then we will tear the third piece of kinesio tape from the middle. After tearing it, we will start adhering the third piece of kinesio tape exactly at the level of acromioclavicular joint by maintaining the shoulder in neutral position. And after that, we will adhere the anterior piece of the kinesio tape at the anterior fibers of the deltoid and posterior piece at the posterior fibers of the deltoid, like this. In this way, we can stabilize the shoulder joint to reduce the pain, but it will allow range of motion, available range of motion to the patient. Next is the Maitland mobilization. Maitland mobilization mainly consists of rhythmic oscillatory movements at joint surface. Here we have to consider the rhythmic oscillatory movements. Here we have 5 grades, but in Maitland mobilization we are using first 4 grades. Fifth grade is the manipulation. So grade 1, this one. Here is the small amplitude movement at the beginning of the range. In grade 2, we have large amplitude movement within the mid-range of the movement. In the grade 3, large amplitude movement at the end of the range. Grade 4, again small amplitude movement at the end range when tissue resistance is limiting. Here the tissue resistance, when it limiting, that is the grade 4 with small amplitude. Again grade 5 is the manipulation. That is the small amplitude and quick thrust manipulation at the end range, just beyond the tissue resistance. So here we have different glides. First one is the posterior glide. We can give posterior glide to increase the glenohumeral flexion and internal rotation. For this, patient position is in supine lying and therapist stand on the side of the patient and apply posterior grade at the shoulder or glenohumeral joint. Next one is the anterior glide. This glide we can use to increase the glenohumeral extension and external rotation. And in this grade or in this glide, patient is in prone lying position and therapist again stand on the side of the patient and apply anterior glide or at the glenohumeral joint. Next is the caudal glide. We can give this glide to increase the glenohumeral abduction. In this glide also patient again in supine lying position and therapist stand on the side of the patient and therapist can give caudal glide at the glenohumeral joint to increase the abduction range. So here we will see how we can exactly apply the anterior-posterior glide. Patient is in supine lying and therapist palpate the greater tuberosity and then place the hypothenar eminence at the greater tuberosity and then give oscillatory glide at the glenohumeral joint. In this way you can see here. We can give 2 to 3 glides per second for almost 10 to 15 seconds and we can repeat it for 2 to 3 sets. Next is the Mulligan mobilization. So what is Mulligan mobilization? Brian Mulligan concept of mobilization with movement is the natural continuance of progression in the development of manual therapy from active self-stretching exercises to therapist applied passive physiological movement, then to passive accessory mobilization technique. Here we have different techniques of Mulligan mobilization for the different range of motions of shoulder joint. But we will see one or two methods or techniques. First one is the Mulligan mobilization for external rotation. Here the patient is in supine lying position and then therapist wrap the towel over the upper end of humerus and then therapist wrap the Mulligan belt around the upper end of the humerus just above the towel and then he will put his feet at the lower end of the Mulligan belt to apply a downward force or pull. Then the therapist put downward pull at the shoulder joint or glenohumeral joint along with distraction. Here you can see he applied the distraction and then go for the external rotation. Here the important thing is we have to maintain this distraction and this pull till the movement is complete. Next is the Mulligan mobilization for internal rotation. Here the patient is in standing position and therapist will use the web spaces of the hand. With one hand web space, he will stabilize the axilla of the patient and with the second web space, he will stabilize the upper end of the forearm and then he will stabilize the whole arm, upper arm with his chest or trunk. Then he will apply downward distraction, downward and outward distraction at the glenohumeral joint and he will tell the patient to move his arm in internal rotation with the help of Mulligan belt by pulling the another end of the Mulligan belt with the normal hand, and he will maintain this distraction till the movement completes. Next is the Spencer technique. What is the Spencer technique? It is an articulatory technique used to relieve restriction and pain at the shoulder joint. That means it's an articulatory technique. Here we have 7 stages. First one is the glenohumeral extension. Next is the glenohumeral flexion. Next is the circumduction with compression. Next is the circumduction with traction. Internal rotation, joint pump. Now we will see how a therapist can apply all these techniques on the patient. In this technique, the patient will be in side-lying position with the affected shoulder at the upper end. Like this, you can see here, patient is in side-lying position and the affected shoulder at the upper side. And therapist, first of all, palpate the shoulder joint for the assessment and then give extension, and this one is the flexion. This one is the circumduction with compression. This one is the circumduction with distraction. This one is the adduction with internal rotation. This one is the abduction with external rotation. This one is the pure internal rotation of the glenohumeral joint. And this one is the joint pump. Here we have to note, except the joint pump, all the movements performed by the therapist will be resisted by the patient. That is the MET. We have to use MET, muscle energy technique, in along with this Spencer technique to gain much more benefit, so that patient can get much more benefit and he will gain much more range of motion. Next is the stretching exercises. So many stretching exercises are available. We can give lots of exercise to the patient, but we will discuss only 1 or 2 exercises that will be very beneficial for the patient here. First one is the pendulum stretch. This is very common and very beneficial exercise for the patient. Here, relax your shoulders and stand and lean over slightly, allowing the affected arm to hang down. Here, the patient have to lean and stand with the help of a table, and his affected arm will hang down. Then swing the arm in a small circle about a foot diameter. Here you can see here, in a clockwise or anti-clockwise, patient can swing or make a small circle. Perform 10 revolutions in each direction once a day. As your symptom improve, increase the diameter of your swing. Or we can progress with this exercise by using small weights in the hands of the patient. Next one is the towel stretch exercises. Here, patient hold one end of the towel behind the back and grab the opposite end with the other hand. This one is the affected hand, this one is the not affected hand. Hold the towel in a horizontal position. Then use your good arm to pull the affected arm upward to stretch it. Patient have to move the good arm so that affected arm will stretch toward the internal rotation. If we want to progress with this exercise, then patient will hold this towel exactly at the shoulder level. It will progress this exercise. Do this 10 to 20 times a day. Next exercise will be the cross body reach. Sit or stand, we can use the position for the patient. Use your good arm to lift your affected arm at the elbow and bring it up and across your body. Entirely gentle pressure to stretch the shoulder. Here, patient will flex the shoulder joint at the almost 90 degree, and with his normal hand, he will pull the affected shoulder toward the body, cross body. This is the cross body reach exercise. Hold the stretch for 15 to 20 seconds. Do this 10 to 20 times per day. Next is the joint active system. We already seen the stretching exercises. Those stretching exercises will help us to increase the range of motion by stretching the soft tissues like muscles, joint capsules, or other soft tissues. But if we want to maintain that stretch, we can use the joint active system. Joint active system of shoulder joint utilize proven principle of static progressive stretch. So we can see here this is the static progressive stretch to achieve permanent restoration of joint range of motion in 3 to 30-minute sessions per day. That means in a day we can use this joint active system for 3 times, and at one time we can give for 30 minutes. Here we can attain 100 degree of external rotation, 90 degree of internal rotation, and 135 degree of abduction. We will apply this joint active system at the new range. When we will gain new range after stretching, at that range we will apply this joint active system, and this will give static progressive stretching for the shoulder joint, and it will help us to achieve permanent restoration of the joint range of motion. Next is the extracorporeal shockwave therapy. So what is it? Shockwave therapy is a multidisciplinary device used in orthopedics, physiotherapy, sports medicine, urology, and veterinary medicine. Its main assets are fast pain relief and mobility restoration. And how we will gain this pain relief and mobility restoration? Shockwave is an acoustic wave which carries high energy to painful spots like trigger points and musculoskeletal tissues with subacute, subchronic, and chronic conditions. The energy promotes regeneration and reparative process of the bones, tendon, and other soft tissue by increasing the blood flow to that region. That will also flush out the toxic substances from the those trigger point area, or those painful spots. That will give analgesia and increase in the range of motion. Next is the his device. What is his device? High intensity stretch device. We already see that uh, JAS, JAS now is the his, HIS. His devices are designed to stretch a joint at its end range of motion to permanent elongate scar tissue that has already formed in the joint. Here one important thing is the scar tissue. We will use this his device in those patients who already developed scar tissue in the glenohumeral joint. In general, patients are giving his device when they are not meeting treatment milestones and have reached a plateau in their recovery with standard protocol of PT. That means the patients are already taking PT management, but they are not getting much recovery from the physiotherapy management, and now they are developing the scar tissue in their glenohumeral joint, and now last option they have only surgical management. But before surgical management they can use his device. His device will definitely give them a solution for the joint range of motion, to increase the joint range of motion. Next is the muscle energy technique. Muscle energy technique is a form of manual therapy which uses a muscle own energy in the form of a gentle isometric contraction and relax the muscle by autogenic or reciprocal inhibition and lengthen the muscle. Here we have different types of, or we have different principles of muscle energy technique, like PIR or reciprocal inhibition or Janda's approach. But here we will not use the Janda's approach because patient is already having very painful condition, and Janda's approach is a very aggressive technique and it will create much more pain to the patient. But if we will But if we want to apply the jaundice approach, then we can use some corticosteroid injections also along with that. That will reduce the pain, and we can easily apply the jaundice approach to the patient. But here we will discuss only two principles. First one is the PIR, second one is the reciprocal inhibition. But here we have uh, so many indications also, but for adhesive capsulitis, we will mainly consider lengthen and normalize the restricted hypertonic muscles and fascia and myofascial restrictions and muscle imbalance. We will go for these indications to treat the adhesive capsulitis patient with the help of MET. So first one is the post isometric relaxation technique. So in this condition, in this technique, patient is in supine lying with the shoulder in 90-degree abduction, and then therapist hold the forearm at the lower end from the dorsal and ask the patient to go for the external rotation of the joint, and therapist give resistance. And after some time, after the hold of 10 second or to 15 second, therapist ask the patient to relax and go for the external rotation to gain new range. In this way, we can apply PIR in the patient. Next one is the reciprocal inhibition technique. In this technique, patient is in supine lying with the shoulder in 90 degree of abduction, and we will hold the patient's forearm at the lower end but from the ventral surface, and ask the patient to go for the internal rotation, and we will resist for the 10 to 15 seconds, and after that patient will relax the arm, and then we will move toward the external rotation to gain new range. Here we have to apply the techniques at the end range of motions. That is a very important thing here, so that we can achieve new range, or we can give this muscle energy technique at the mid range, available mid range also. Then we will progress toward the end ranges of the shoulder joint.
Dry needling for deltoid muscle. So first of all, we will see before starting any dry needling session, what are the general standards and guidelines we have to follow. Nails should be smooth and short before giving dry needling. Here's the warm and clean approach. His or her hands with soap and lukewarm water. So before giving any treatment session, you have to dry your hands by using single-use disposable paper towels. It's a very important. We have to get a signed consent from the patient before giving dry needling session. The skin over which the treatment will be applied should be clean. Now we have a needle in our hand. Here we have to take care. We should not touch the needle shaft. So next is the journal standards and guidelines for dry needling during treatment. We must ensure that during a single treatment session, we must treat 3 to 5 muscles, not more than that. Then after that, we have to find out the trigger point. To find out the trigger point, apply firm pressure in the perpendicular direction over painful muscle fibers, and patient will show jump sign at trigger point. But here we have to take care. When we are going to palpate the trigger points, our hands should be uncovered. After palpating the trigger points, then wear sterile gloves before applying dry needle. So first of all, dry needling for anterior deltoid muscle. So patient is in supine lying position, and then palpate the trigger points and place the dry needle with guide tube over the trigger point area, and then tap over the needle and remove the guide tube, and then insert the needle inside the trigger point muscle, and then do blistering to elicit the reflex. Leave the needle inside the muscle for some time. Then put a cotton over the needle.
Thank you, sir. So this one is the management approaches for the adhesive capsulitis. But here I would like to add something. For adhesive capsulitis management, we can use uh, different techniques along with the conservative management. Like for the if we will give electrotherapy management, along with that we can use some advanced management like dry needling or muscle energy techniques, so that we can get more benefit from the whole treatment procedure. This will give us result in a very short time period. Thank you, sir. Thanks a lot.
Thank you, Dr. Varun. I was wondering how you can cover up so many of things within a short span of time. You have given all the techniques that can be applied onto the adhesive capsulitis within the half an hour. It is starting from the Maitland, Mulligan, muscle energy technique, dry needling, his, and all this thing is there. But a little question is there, sir. I find it out. It's a blanket term is there. So can you tell us the few assessment part, how to diagnose it? Okay, this is the only injury, because sometimes it got mimic with the painful arc syndrome. Then there is a capsulitis is there, or it is a, so lot of conditions are there. So how you would say up this test is there that would say, okay, this is the thing.
Actually, sir, for adhesive capsulitis, if we will go for the radiological imaging, that will not work. Actually, it's not a condition that will be present in the radiological imaging, like X-ray, MRI, like that. If we have to diagnose it, we can go for the radiological imaging, but that will differentiate the other conditions, like any injury to the capsule, or any tear at the joint capsule, or any fracture, bone fracture, like that we can distinguish from with the help of the radiological imaging. And if we will go for the special test also, like in the Maggie books, from the Maggie book, for the adhesive capsulitis, I think there is no one specific special test present, but we can diagnose other conditions with the help of those tests, like kidney test, or any other test we can use to differentiate the different conditions there, as you said. But for the adhesive capsulitis, the main thing is passive range of motion is restricted along with the active range of motion. If we will see the passive range, at that time, if patient is not able, we will not able to move the arm, especially the external rotation and then abduction and then internal rotation, that will definite, or that will diagnose our condition, that is the adhesive capsulitis.
Another thing is there, Dr. Varun, the thing is what comes first, egg or the hen? And the same thing occurs here, pain and the restriction in the range of motion. So which we should treat first, pain or the restriction in the range of motion?
So in the starting stage, maximum time at the patient we comes with the pain only. But in the first stage, patient is not coming to us. He is waiting for the recovery itself, or he is taking just painkillers, or waiting for the recovery or reduction in the pain. And when he come to us, at that time he is having a second stage, and in second stage patient starts with the restrictions also. So we will see pain along with the restrictions in our OPD clinic or OPD patients. Actually, it's my PhD topic also, and till now I have seen 210 patients of adhesive capsulitis, and most of the patients are coming in the second stage, not in the first stage. At the first stage, they are taking medication from the local practitioners, or from the pharmacy shops, and after that, when they are feeling that now shoulder is not going upward or above the head, after that, when they are facing problem in combing or other daily activities, at that time they are visiting our OPDs. At that time we will see patient is having pain, severe pain along with the restrictions. And if the patient is coming after the symptoms start from just before 4 months or 5 months, at that time patient's shoulder is almost 90-degree shoulder abduction is very difficult to achieve. At that time we can easily diagnose it's adhesive capsulitis, not other than other condition.
So I could find it out ki we should treat the both the things simultaneously,
Yes,
because
we
it
have
won't
to
be like
treat.
this ki we are treating first.
If we will treat pain, then only we can achieve range of motion. Otherwise, patient will not allow us to move his shoulder, or even he will not allow us to touch his shoulder, because it's a very painful condition. We have to treat the pain first, then we will go for the increase in the range of motion.
Sir, you have shown the his technique. Is
Yes,
it
sir.
available in India?
No, sir. Actually, it's not available in India. Actually, I got this one article that's on that basis. Actually, I mentioned this technique here to introduce this technique with our physio fellows, so that they can at least know about this technique, that it is available in this world or in other countries, so they can use whenever it will be available.
Thank you, Dr. Varun. Thanks a lot for coming on the Rehabilitation Science group platform.
Yeah, thank you, sir.
In a nut of the shell, you have tell us a lot of techniques and how to diagnose it and what to choose for the correction of the adhesive capsulitis.
Yeah,
thank you,
sir.
Dr.
Thanks a lot,
Varun.
sir. Thank you.
Thank you, sir. Thank you.
Thank you, Dr. Varun.
Yeah, thank you.